Hello, everyone, and Happy New Year. Welcome to our first episode of Values in 2025. How crazy is that? This is episode 5 of season 2, and I am freaking out about who we were able to get as our guest today. So I'm going to get her linked on with us here, and we will dive in. I don't know where you all are in the world, but it is really cold where I am. Hopefully you are staying warm and doing well, and you had a wonderful holiday season with everyone that you hold dear. So, oh, here we go. I think we did it. Yay! Hi.
Hi, can you hear me?
Yes, I can. Can you hear me?
Perfectly.
Um,
Hi.
Amazing. Great. Well, welcome, Dr. Koepp. Thank you so much for being here.
Thanks for having me. I'm delighted to be talking with you today about mental health and aging.
Thank you. And where are you calling in from? Where are you
I
located?
live in Burlington, Vermont,
Oh, okay, so it is cold there probably then,
and
yes?
snowing. Yeah, it's
Oh, nice.
beautiful.
It is. I was just saying before you came on that it is very cold here today. I know that at my daughter's school, they're not even letting them go outside for recess. It's that cold. So yeah,
Where are you?
I'm just outside Toronto in Ontario. Yeah. So it is cold. Well, before we dive in, let me just share with everyone a little bit about who you are. So, this is Dr. Regina Koepp. She is a geropsychologist, and yes, we will explain what that means. She's Stanford trained. That's cool. I loved reading that. And she is a board certified clinical psychologist and the founder of the Center for Mental Health and Aging. Now, for 20 years, she's worked with older adults and their families in some of the largest healthcare systems in the US. And like so many of our viewers and followers, she has experienced firsthand the difficulty of helping older adults and caregivers find the mental health support that they need that is really specific to the older adult demographic. And this is really where your mission came in, right? And you've made it your life's work to ensure that mental health and senior care professionals have the tools they need to specifically support the aging population with mental health, which I think is such an interesting niche. And I was just talking with someone the other day who is dealing with a 93-year-old mother who is having some sort of, I'm not a psychologist, but the term he used was some sort of psychotic break, and they don't know how to support her because she also sort of has dementia. Like it's such a
Uh,
confusing world. And so I think it's interesting that you have found this very specific niche to be able to support our ever-growing aging population.
yeah, thank you so much. And you're exactly right. Even to address the question about the 93-year-old who is having what they think may be a psychotic break, I
Yeah.
um, it gets so complicated because many older adults, people 65 and older, more than 80% have a chronic health
Mhm.
condition. And when we have chronic health conditions, our risk for mental health problems increases, like anxiety or depression.
Yeah.
Those are the most common. And
Mhm.
then the older we get, the greater our risk for cognitive disorders.
Right.
So you said she had a dementia disorder, though cognitive disorders are not typical with aging, but
Mhm.
the older we get, the greater our risk.
Yeah.
And so if this woman, and I don't know her, but this just speaks to the complexity of
Right.
why we need more people trained in this, because this woman has dementia and has not experienced psychosis in her dementia before, and all of a sudden is hallucinating or
Mhm.
delusional, then that might give some clues to the family and the doctors for what might be going on. Because when people have dementia,
Mhm.
their cognitive reserve is lower, and that increases their risk for what's called delirium,
Mhm.
which is an acute medical emergency. So something might be off physiologically in her system. She might
Right.
be living with an infection that needs to be treated, or malnourished, or
Mhm.
have some irregularity in her labs that needs to get stabilized, and that would treat the psychosis. The psychosis might be a symptom of a medical problem, even
Right.
though she has a dementia disorder. And so it gets really complicated with older bodies and older
Mhm.
brains, which is why we need people trained in this, and why we
Yes.
need more attention to this.
Definitely. No, for sure. I mean, it's interesting when you say that because I wonder if not only in the older population, but in all populations of any sort of age demographic, if we actually um if physicians, the people helping us, think, oh, I wonder if this is a symptom of something else happening, as opposed to it, being specifically a mental health issue. And as you said, as we age and our bodies become more complex in many ways, like that just maybe increases the chances of that. So that's really interesting. And I appreciate you touching on that. I'm going to make sure that my friend actually watches this, that they hear that. But let's dive into our
Yeah,
questions here. So let's explain to everyone, let's just get to the basics. What is geropsychology?
yeah.
And can you break that down for everyone and kind of explain how your practice as a geropsychologist might be a little bit different from what we perceive a typical psychologist practice to be?
Yeah, sure. So, a geropsychologist is simply a psychologist who specializes with older adults. And in my book, older adults, and this is not just my book, this is older adults are 65 and older.
Yeah.
However, I think many 65-year-olds I don't think qualify
Yeah.
for. So my average age is 85, I
Okay.
would say,
Yeah.
of
Yeah.
a patient. And however, I would think of it more like stage than age,
Hmm.
because one 65-year-old can be very different from another 65-year-old.
Yeah.
I'm even thinking about myself. I'm 48 and I have very little children. I have a
Okay.
7 and 9-year-old, and I know other 48-year-olds who are grandmothers. And so
Right.
our stage of life is very different. So I kind
Yeah.
of think of it more of stage rather than age.
Okay.
However, I don't think being age blind is helpful either. I think
Hmm.
we need to be age inclusive and sort of understand what comes with being 65 or 75 or 85
Hmm.
or 95 or 105. And so gero is short for
Hmm.
gerontology. And gerontology is the study of older adults in society. And then psychology, of course, is the study of human
Hmm.
behavior and people and the biopsychosocial spiritual experience of, human experience.
Hmm.
And then the practice of psychology, or at least I'm a clinician. So geropsychologists could span from researchers who don't see patients
Okay.
to clinicians like myself who work in practice or in medical settings or medical centers working with older adults and their families. But it's
Hmm.
really somebody who has a pretty comprehensive and deep knowledge of the aging experience, intersections, the sort of, they tend to be more integrationists,
Okay.
meaning integrating biopsychosocial spiritual aspects of aging.
Hmm.
And that's because um, people are integrative beings, but because also we see a lot of overlap between chronic health
Hmm.
conditions, psychological health, spiritual health, and end of life, and things like that.
Right. Yeah. And so, in your practice, what are some of the most common misconceptions that you're seeing with regards to aging and mental health? Like, what is an average person who's caring for their parents just having a really inaccurate view of, right? When they're
Yeah.
taking care of them and there might be a mental health issue at play.
Yeah, this is such a great question because we're influenced by society, and this is family members and clinicians
Hmm.
alike. And
Mm.
so there are a lot of ageist messages in society, meaning like bias and discrimination or
Yeah.
stereotypes about what it means to grow
Hmm.
old. And what happens often for adult children who may have concerns about an aging parent is that we project our fear and dread
Hmm.
onto our parents' experience.
Yeah.
And there's some interesting research that shows that um, the older we get, the more prepared we are for end
Hmm.
of life and changes in our health, and the less fearful we are about those experiences.
Right.
Whereas a 40-year-old or 50-year-old tends to have higher levels of fear about
Hmm.
health conditions and lower levels of preparedness.
Hmm.
And so, but we project that fear, or have a tendency to, on our older loved ones. And then we might come in really hot and start getting demanding, like you need to go to your doctor and you
Yeah.
need to take your medicine and you need to exercise more and you need to change your diet. And we start getting like maybe a little prescriptive and
When really it's, I need to do all those
yeah,
things because I'm getting older and I haven't done any of it.
yeah.
Yeah.
So I see a lot of projection. I see also, misinformation about what's
Hmm.
typical with aging and
Yeah.
not typical with aging. And
Hmm.
so because there's a lot of misinformation, and it's not the adult child's fault either. A lot of clinicians don't have the education either about what's
Yeah.
typical with aging and not. And so, because there's misinformation, people are not adequately informed about how to help. And
Hmm.
so, like for example, if we're talking about mental health concerns, so say your older loved one has two chronic health conditions, just came home from surgery maybe a couple of weeks ago, and a dear friend died,
Hmm.
right? So there might be a period of grief, and
Right.
say that grief or um, transforms or triggers some anxiety.
Hmm.
And maybe your older loved one's more concerned about what's going to happen to me,
Hmm.
my mortality.
Yeah.
I just think of maybe like a sort of catastrophizing and a sort of anxious spiral.
Hmm.
And if the adult child thinks, well, this is normal,
Yeah.
this is typical, because all these things are just happening. And it might be okay for a couple of days, but
Hmm.
if that extends beyond a couple of days, I would say that that's maybe not typical
Hmm.
and maybe needs some investigation and mental health support.
Hmm.
So there's a lot of misconceptions about what's typical with aging and not. So like this idea that depression and anxiety are typical with aging,
Hmm.
and they're not. Or this idea that dementia is typical with aging, and they're not.
Right.
Or an idea that older adults are rigid and will never change. So why would we invite them into mental health care if they're not going to change anyway?
Yeah.
And that's also not true. Older adults are capable of change,
Yes.
or that mental health treatment is not effective for older adults. That's a common
Hmm.
one that I
Yeah.
hear, and that's not true. Mental health treatment is equally effective for older adults, and there are even some studies that show that older adults who complete substance use treatment
Hmm.
have greater outcomes, even a year down the road, than younger age groups.
Hmm.
So there are a lot of misconceptions, and if the general population and clinicians, many clinicians don't know this either,
Yeah.
have these misbeliefs or hold this misinformation, they're not going to be reaching out to, um, you know, inviting their older loved one to meet with their doctor, to see what's
Hmm.
going on, to get
Yeah.
engaged with care.
No, exactly. And I mean, I think about, so I'm 38, and I think about just even my peer group around me. There are people who I know have tried different types of therapies and been like, oh, it's not for me, just like immediate, like negative reaction to it. And I've been in and out of therapy for years. I think it's just like this amazing tool to have in your life all the time because things happen and it's great to have an impartial human being around. And I think that it's finding the right type of therapy, but then also the right person, the person that
Yeah.
you feel you can form, because it's a very intimate experience, therapy. And so when we create these generalizations, as you said, that older adults aren't going to benefit from mental health treatment, really it's just finding someone that they can connect with. And who knows who that person is. I say to the families I work with a lot when I'm dealing with like an adult child in their 50s or 60s and they have an aging parent and the parent won't listen to them at all. I'm like, well, of course they're not going to listen to you. They changed your diapers. That's not going to happen. Like, why would they listen to you? They're starting to feel controlled by you, even if the adult child's going about it in just the most empathetic and kind way. It's still annoying. No one wants their kid taking care of them. That's not something that we go for. And so I always say bringing in a third party could be helpful. Sometimes bringing in a grandchild I see to be beneficial. I've seen that in my own life with my grandfather, who sometimes opens up and talks to me more than he does his own children. And I think it's because he didn't raise me. And so there's just this like degree of separation between us, even though I'm still family. So I think it's too bad that there is this misconception that older adults can't benefit from mental health in the same way. I mean, there's a lot of studies coming out now, and I'm sure they connect in some way, where they say, there's this whole misconception that older adults can't learn new things, can't be taught how to stay in the workforce longer with the advancement in technologies. And it's like, no, it's just about figuring out how to teach them. And we go out of our way to find all these different ways to teach kids nowadays with this whole no child left behind thing. So we're going after the kids, figuring out all the ways that they learn and the ways to support their different types of learning strategies and brains. But why aren't we doing that for aging adults so that they can have a purpose post-retirement and still thrive and not develop potentially mental health illnesses as well. So I love that you are really leading that forefront, and hopefully it's something that just becomes more and more prevalent and will be needed as the boomers are just going to shock us. And I always say they're just going to live forever. We just got to be ready for what that's going to be like.
And us too.
Yes,
I
well
mean,
then
and
that's
that's
after. Exactly. Yes.
Another, I think, barrier for I've worked with thousands of families. I think
Mhm.
some older people will include their kids,
Yeah.
some won't, and I think one of the barriers, though, to an older person inviting an adult child into their care,
Hmm.
also is many older adults don't want to be a
Yeah.
burden on their children,
Hmm.
and and uh, that's a huge concern when people need care and
Hmm.
caregiving. And so I don't think it's only that I change your diapers. I think it's also
Yeah.
that I don't want to ask you to change your life for me. And then if I do, where are the boundaries
Hmm.
here? And then family roles begin to
Yeah.
shift and the ecosystem of the family begins to shift.
Hmm.
And every family at every stage of life has resistance to shifting like a
Yep.
shifting a family system. And so it's not only that I changed your diapers, it's
Hmm.
also that I don't want to be a burden.
Hmm.
The system is going to change, and there's going to be a lot of fallout with that change because that's the nature of change in systems. And
Exactly.
and that would happen in an already vulnerable time.
Hmm.
And so I think there are natural defenses that are up during a vulnerable time, and then the risk of the system changing with an illness
Hmm.
and caregiving, or preparing advanced care planning. There's a lot of reasons to resist the
Yeah.
change there.
No,
Yeah.
for sure. And I mean, you were talking about families there, and I noted that you don't just work with individuals, sometimes you are working with families. And so maybe you could talk about what role families play in supporting somebody's mental health, maybe not being in the room, as you
Yeah.
said, but providing that support to their aging loved one as they get older. And how do you, when it's applicable, bring families into your therapeutic approach to support the aging loved one?
Yeah, this is such a good question. You know, um, like I said, my average age of a patient is
Hmm.
85, and and that generation experienced a lot of mental health stigma in a
Okay.
way that I think current generation, younger generations now are not experiencing. There's
Right.
more public discourse about
Hmm.
mental health care. There's a reduction to reduce, there's intentions around reducing stigma,
Hmm.
and older adults didn't get that.
Yeah.
And they don't have the same exposure. They didn't
Hmm.
have social media to talk about mental health conditions, right? There's tremendous stigma for many older adults, and that's one of the barriers to older adults getting mental health care. And this is
Hmm.
where adult children or grandchildren could be so helpful
Hmm.
because they can say, hey, like you just did yourself, Mallory, you were like, I engage in my own psychotherapy and it's
Yeah.
been so helpful for me. And this is what it looks like. And
Hmm.
this was my experience. And you don't think I'm crazy. Well, you know,
They might.
yeah.
Who
But
knows?
you can make a joke about that. But you also
Yes.
know me intimately, right?
Yes.
Like,
Yeah.
and how it's helped me. And this is how
Hmm.
it's helped me. And this is what it looks like to sort of destigmatize it.
Right.
Or to say, when I was going through something similar,
Hmm.
like I was going through a period of depression, this is what it looked like for me.
Hmm.
And I wonder if that's happening for you.
Right.
And to lean in and sort of start that awkward conversation. Or if
Hmm.
you see some symptoms, um, maybe saying, I'm concerned.
Hmm.
You're not
Yeah.
yourself. You're spending a lot of time sleeping, and that's not like you.
Hmm.
You don't seem to be enjoying your life, and you had so much zest for life a couple of
Yeah.
months ago. And that doesn't seem like you. Like, can we
Hmm.
talk about that? And
Right.
I think just having an authentic, awkward,
Hmm.
honest, caring conversation can go a long way in
Hmm.
bridging an older person to care. And then to saying, like, if you heard this program, to saying, oh, there are lots of resources geared toward
Yeah.
your age group, so that,
Exactly.
your resources might not be the same as
Hmm.
mine. And that's okay. You might have different concerns, maybe about brain health than I have.
Right.
But like to get connected or to bridge the person to resources that might be appropriate for them.
I think a lot of times people go out of their way, whether it's with the aging population or not, to avoid the awkward conversation with a family member, right? They do everything they can to avoid it. And when we're doing aging and end of life planning at Viive, we host family meetings a lot, and the clients will be like, "This is going to be awkward." And I say, "Yeah. Like it, of course it is. You've never talked about these things before. These are heavy hitting, very intimate subjects. It's going to be awkward. So let's just acknowledge that across the board. Everyone's going to not feel comfortable being here, but everyone's here because they love each other and they understand the importance of these conversations. And the more and more we do something, the more and more we can become destigmatized to those uncomfortable feelings that are associated with it. And that's something we've been really lucky to see with families that we've worked with. We've been around for 4 years now, and we see them being able to have more conversations. The frequency has increased, but then also the depth that they're able to go into, also without our support, which is really what we want them to do at the end of the day. I shouldn't be at every family meeting that happens. And that's really just because they allowed themselves to sit in the discomfort
Yeah.
and figure out what works best for their family to process that experience. So um, regardless of what the topic is, allowing your family to sit in some discomfort isn't a burden, isn't a bad thing to put them through. It's good because in the end, I think it actually makes you tighter as a family unit when you allow those conversations to take place.
Yes, I agree. And I think it requires each individual in the family, each adult, to do
Mhm.
their work in
Yes.
managing what comes up for them.
Hmm.
You know, like a lot of times, families who come into therapy might say, "You weren't here for me, and
Hmm.
now you're
Yeah.
asking me to be there for you." And so I think to do your work in understanding where your boundaries are, or um, where you are willing to help or not, and then what sort of
Hmm.
supports could you help your loved one brainstorm if that's not a good um, time for you to be involved, or
Hmm.
type of caregiving experience or end of life experience for you to be involved. So I think knowing yourself and knowing your boundaries, and that's hard to
Hmm.
do because it's hard to predict all of the scenarios that come up around
Yeah.
chronic health conditions and end of life care planning and end of
Hmm.
life care. And so, but the more you know yourself and um, know your triggers and
Hmm.
what you are and aren't willing to do, I think the easier those conversations go.
Definitely, yeah. Now you talked a little bit before about ageism, and at Vive we talk about that a lot and how ageist beliefs can actually hold people back from properly planning for their future and creating what we call an aging and end of life plan. So in your work, how are you seeing ageism impact clients and their families?
Yep. So one is earlier, what that we talked about with projecting our own fears and
Hmm.
dread onto the
Yeah.
aging experience. I think another is this idea that it can't change. And older adults might internalize these beliefs too. They get the same
Right.
messages we
Yeah.
do. And so sometimes in psychotherapy, I'll say, you know, can I tell you about the benefits of therapy, even among
Hmm.
people over 70 years old, or even among
Right.
people, or like, for example, because mental health conditions in older adulthood is not widely discussed. We don't
Hmm.
know even how to talk about it. So, like, for example, anxiety disorders. Uh, there's generalized anxiety disorder, which is an anxiety disorder, is more common between 65 and 80, but
Okay.
over 80, and it's not common, but
Yeah.
it's of the anxiety disorders, it's the most common. But over 80, it's not the most common. Over 80, a fear of falling, which is an anxiety
Oh,
disorder, is more
yeah.
common
That makes
than,
sense.
and then agoraphobia, because if you're afraid to fall, you might not go outside your house.
Okay.
And then
Fair. Yeah.
that supersedes a general anxiety disorder. And so, but
Hmm.
if we're not talking about these things, people don't know to look out for them and then to
Right.
help their loved one get support and care.
Hmm.
And fear of falling is treatable with
Right.
a combination of therapy and physical, like talk therapy and physical therapy.
Yeah.
And and so I think that's one way, is that there's structural ageism and that information is not being shared widely structurally in medical
Mhm.
systems and healthcare systems and on social media. So congratulations for changing that.
Thank you.
Um, I also think, you know, like we talked about earlier, this idea that people won't change. and change is not determined by age.
Hmm.
Willingness to change and rigidity is more personality, and also change is hard for everybody.
Yeah.
Um, I'm trying to think of other ageist examples. Or this idea that the older person's experience is less relevant because they're
Hmm.
older.
Yeah.
And that's not true. Or I see a
Mm.
lot of, even in the healthcare system and in families, not every family, but in some families, um, people talking over the older person,
Hmm.
or not prioritizing the needs or giving voice,
Yeah.
sharing space with the older person, overlooking
Hmm.
them, even in meetings or family meetings,
Hmm.
wanting to sort of bulldoze medical appointments or other sorts of appointments, I think
Hmm.
is potentially an act of ageism, um, making that person's wishes
Hmm.
irrelevant and sort of um, degrading the dignity of that person.
Right.
Yeah.
Right. Now, for our listeners and people who are going to watch after, do you have any advice on how they can proactively plan ahead to manage their own mental health or to be supporting one of their loved ones through their mental health as they kind of are getting into those active aging years and then moving towards end of life?
Yeah, and somebody who's watching now just also provided some excellent
Oh,
examples of
yeah.
ageism, of dismissing an older person's opinions and feedbacks.
Yes.
Perfect. Exactly. Yeah.
Hmm.
Yeah. So here's some advice for sort of optimizing mental health. This is true for everybody, and this has particularly grand effects for older people. So social connection is
Hmm.
key to living well and reducing risk for illnesses. And so
Hmm.
social connection doesn't have to mean a lot of relationships. It has to mean quality relationships
Okay.
and feeling like a sense of belonging and contribution in
Hmm.
those relationships. So that's really key. I think even if you know, if you're concerned about an isolated older adult, maybe they're not your family, but they're just somebody that you know and care
Hmm.
about, and they're isolated. There was even a study done recently in 2024 that looked at Zoom phone calls with isolated older adults and
Okay.
found that, and so these older adults did not have much family support, much connection, didn't leave their homes very often, and
Hmm.
found that even as Zoom phone calls were helpful in their quality of life and their willingness to go outside their home and engage in society and the community. And so connection is key, and social relationships and quality relationships are key. And it's key to physical health and mental health and
Hmm.
spiritual health. Um, there's so much you could do if you have access to quality nutrition, if you
Hmm.
have access to strength-based exercises,
Yeah.
you want to consult, the older person might want to consult with their doctor. And this is good advice for all age groups.
Yeah, of
And
course.
I think changing your mindset about aging, if you think
Hmm.
that it's horrible to grow old and there's nothing waiting for you there that's of substance,
Hmm.
you're more likely to have more illnesses and a shorter lifespan.
Hmm.
If you think there is a lot to be gained from growing older, and
Hmm.
see the value in it in terms of wisdom and self-compassion and um, opportunities to impart your knowledge to other people, and
Hmm.
the gains that you have in life or have acquired through life, then you're more likely to live a better quality
Hmm.
life and have better mental and physical health outcomes.
Yeah. And something you mentioned there about like your outlook on aging. It's interesting. So all my friends are sort of between like the 35, 45 age bracket right now, where I'd say that for probably the first time we're seeing like aesthetic signs of aging starting in us. And for females, we might be feeling that perimenopause feeling coming on, right? And it's interesting how myself, but then even some colleagues that I have in the industry where we say the same thing you just said, like have a good outlook on aging. It's interesting how like our automatic reaction is to have a negative outlook on aging, whether that's from what's been imparted on us from media and whatnot. But then I've also been reflecting on the aging people in my personal life. What have they said? What has sort of been ingrained in me? And I have a 7-year-old sorry, she's not 7. She's about to be 9. I have an almost 9-year-old daughter. I don't know what happened there. And I really try to make sure now that I talk about aging in a positive way because I don't know what was said to me at some point that has become ingrained in my mind that getting older is a bad thing. And so anytime my daughter comes in and she sees me looking in the mirror or whatever, I try to say something nice for myself and for her to hear as well about my aesthetic appearance, and also try every time I get grumpy about some ache and pain, I try to like take a moment and reset that thought because I immediately just go to the negative, getting old sucks, and like that's it, right? And having to reset that, even as a person who preaches this and talks about it all the time. So I can only imagine for people that aren't in this similar industry that we have, that it's even harder to, reset that mindset and have a positive outlook.
Yeah. So you're talking about there's a researcher at Yale, Becca Levy, and
Okay.
she's the sort of premier researcher in ageism. And
Okay.
she talks about the stereotype embodiment theory related
Okay.
to ageism. And so what this means is that all throughout our life,
Hmm.
as early as toddlerhood, we're internalizing messages. We're hearing messages and then internalizing them about aging.
Okay.
And and ageism disproportionately affects older people. So, um, in young adulthood, people experience ageism where there might be discrimination around, like, you don't have enough experience to do this
Yeah.
job, even though the person
Yeah.
might have plenty of experience. And so, um, older adults experience ageism more, and it's more harmful for older adults because they don't.
Hmm.
Well, a young person grows out of a sort of age vulnerable group.
Okay.
They grow into age privilege, where older
Right.
adults never grow back into age privilege. They
Okay.
just
Yeah.
experience more and more ageism. And
Hmm.
so, in Becca Levy's discussion of this stereotype embodiment theory, she says we internalize these messages all throughout our lives, and they operate unconsciously in our psyches, in our
Hmm.
systems. And that informs how we take care of ourselves or not.
Right.
And now we're seeing more and more research that your behavior in your 30s and 40s has impact on your dementia risk later
Yep.
in life, right?
Hmm.
And so, and other health risks as well, including your beliefs about aging when you're 30. Becca Levy did a study. Your cardiovascular risk is higher if you have negative age beliefs 30 years later when you're
Wow.
60. Yeah. So how you think about things matters. But so you're internalizing this,
Hmm.
and these ideas are operating unconsciously, and that influences your behavior.
Hmm.
But then it becomes particularly harmful when you reach the age that you have stereotypes about.
Right.
So it's
Hmm.
not just like, oh, older people are negative this and negative
Yeah.
that. You're also
Yeah.
talking about your future self.
Yes.
My future self will be negative this and negative
Right.
that, because hopefully we will all get there
Right.
and to older adulthood. So this idea that the beliefs become particularly harmful
Hmm.
when we're the age that we have stereotypes about.
Hmm.
And so that might be when you have gray hair, or when you
Right.
have wrinkles, or when um, I don't know what it is, when you're
Yeah.
85
Yeah.
or 70, whatever it is in your mind.
Yeah.
And so this is why we have to be so and why we see more health consequences at that
Hmm.
stage of life. One,
Right.
because we are more physically vulnerable at that stage of life, but two, because these negative beliefs have had time to ingrain and
Hmm.
influence our behavior. And so we have to do a lot of work to uproot these negative beliefs, unlearn them, and relearn something more positive.
Oh, well, I'm gonna have to work even harder
Yeah.
now that you told me that. Also, I'd love to read. What'd you say her name was? Rebecca
Becca
Levy?
Levy,
Becca Levy?
Levy.
Okay, I'll try to
Basically,
look
all
that
of
up
the
and link it.
ageism
Mhm.
research you've ever heard comes from her.
Good to know. All
Yeah,
right. And she's out of Yale, you said?
that's right. Yeah.
Okay, cool. I'll
Hmm.
try to find it and add it into the comments on this post so if people want to check it out. We're going to take a little bit of a turn here,
Okay.
although it's still in the mental health area. And we have talked about MAID, medical assistance in dying, before on this channel. And so if there's anyone who wants to pause the video or come back after, that's totally fair. I'm just giving everyone a heads up. We are going to touch on that right now. So you're working with clients and families who are considering or who are going through the process of thinking about medical assistance in dying. dying. Now, depending if there are people calling in from different states or different provinces, there might be a different term for this. In Ontario, we use the term MAID. So, what kind of impacts can MAID have on both individuals and their family members, especially in terms of their mental health?
Hmm. Yeah. So just to define MAID, so medical aid in dying, also in the US, we call it MAID or death with dignity. And depending on the state,
Hmm.
they also will use different terms. So this means that a person has a terminal illness that has been diagnosed by, oh, it depends on the state, but needing to be diagnosed by one or two doctors. Often it's two doctors,
Hmm.
and you have to go through a series of requests
Hmm.
depending on the state. It's bound by each state's laws,
Hmm.
and not every state honors. Or I don't know, in Canada, is it a national? I think it's a national approval for MAID.
Yes. Yes. Again, the province, I think, I don't know exactly if the name is different from province to province or the rules are, but I'm pretty sure it is a national. Yeah. Hmm.
And so how it works is that you have to have a diagnosis of a terminal illness at least in the United States, in the states that honor MAID, with 6 months to live or less.
Hmm. Yeah.
And then you can request in certain states a physician to prescribe a lethal dose of medicine that you have to self-administer yourself. Your physician cannot administer it, a family member cannot administer it, and so you have to be the one to self-administer it. And for many adults who have a terminal illness, if we're talking about mental health related to this, there was a study done with terminally ill cancer patients in the United States, and they found that like 44.5% wanted to hasten their death, but only 17% had a persistent wish to die.
Hmm.
And so I'll say that even if you're living with a terminal illness, you might not have a persistent wish to die or a desire
Hmm.
to hasten your death through something like MAID or some other means. But of those people, only 12% talked with their doctor about medical aid in dying.
Hmm.
So it's not the most common experience in end of life. It's a unique
Hmm.
experience.
Yes.
And so I think that's important to know, that many people want to die by natural causes,
Hmm.
and as I said earlier, as we get older, and so I think this is also unique to, certainly MAID is not unique to older
Hmm.
adults, but being more prepared to die is unique to older adults, that we become more
Yes.
prepared to die the older we are and
Right.
less afraid of dying
Hmm.
the older we are. And there's some
Hmm.
good research around that as well. And so when a person has a desire to hasten their death, we do have to differentiate desire to hasten death from depression, because
Okay.
depression can cloud a person's judgment,
Right.
can also increase the risk for
Hmm.
suicide, where medical aid in dying and suicide are not the same. That
Right.
medical aid in dying is an end to suffering related to a terminal illness, where
Hmm.
suicide might be a and to suffering related to mental illness
Right.
or distress or something
Hmm.
acute psychologically that could be treated as well. And
Hmm.
so when somebody has a desire to hasten death, there's some good tools to help differentiate desire to hasten death from depression and then to treat the depression.
Hmm.
However, there might be people who don't have depression, or even who do have depression, who also have um, a substantiated, worthy desire to hasten their death with the use of medical aid in dying.
Hmm.
And when people tend to choose medical aid in dying, they tend to feel pretty good about their choice.
Hmm.
They that they have a sense of control when aspects of their life are out of their control.
Yeah.
Um, the state of Oregon in 2022, so the state of Oregon in the United States was the first state to honor death with dignity
Okay.
or medical aid in dying. And they did a survey in 2022 of all the people who enrolled in, they call it Death with Dignity in the
Okay.
state. And they found that they asked, what were your concerns about your end of
Mm.
life that sort of inspired you to participate in Death with Dignity?
Right.
And 89%, and I have some of the stats, so I'm gonna pull them over so I get them right.
Okay. All right.
89% said that a loss of their ability to participate in activities inspired
Mm.
them.
Okay.
86% said a loss of autonomy.
Yeah.
62% said a loss of dignity,
Mm.
and 46% burden on family. And so you know, dignity, autonomy, and not able to participate anymore.
Yeah.
Like those were the top reasons. And so when
Mhm.
people participated, and in that year in Oregon, I think the majority of people who received a lethal dose of medicine took it. I think something like 19% didn't,
Okay.
and maybe their terminal illness took their life before that, or maybe they chose not to. We
Right.
don't know the answer to that.
Hmm.
And then family members, though, some research has shown
Hmm.
that, you know, here's the thing about end of life, and also true with medical aid in dying. You know, end of life is a common human experience.
Hmm.
We're all going to experience that, and
Right.
similar to grief, right? It's a human experience that we will all know,
Hmm.
and it's unique to us. Like our experience of it is unique because we are
Yes.
unique
Yeah.
individuals, and so it's both. It's like common and unique, and
Hmm.
so these are generalizations, right? Often, so I'm going to share some statistics about families, but not all family members do well with medical aid in dying.
Yeah.
So most do.
Okay.
However, there are some who experience post-traumatic stress reactions from it, have a very
Oh,
negative experience of their loved one moving
okay.
through MAID or using MAID, have a lot of moral dilemmas and spiritual dilemmas that are difficult to hold,
Okay.
and that um, can create a psychological and spiritual conflict for
Hmm.
them and their family.
Okay.
Other family members, so in larger studies, have more positive
Okay.
outcomes. So one study looked at, and I have these resources because I just did a 6-hour continuing education training for mental health providers on medical
Oh,
aid
that's
and dying.
great.
But so family members who are their loved one used MAID, and now they're in
Mhm.
bereavement, or they're in grief. The research has found that they have less traumatic grief symptoms, and when they were surveyed, lower levels of a current feeling of grief and less post-traumatic stress reactions. And then, so the question is why?
Right. Yeah.
And the reason around that is the having the opportunity to say goodbye.
Yeah.
You have these rituals where you get to say goodbye,
Hmm.
and you know it's happening. Also, the personality traits of the person who opts in for MAID may be a very matter of fact person, a person who
Hmm.
has honest
Yeah.
conversations, who
Yeah.
says it like it is. And so
Hmm.
that might also reveal that there might be greater acceptance of their illness and prognosis of the illness. So more conversations with family, so more opportunities to prepare for death, and also for the family member to prepare for grief and
Right.
experience a sort of healthy anticipatory grief.
Hmm.
What's very complicated for family members is often the research shows the family member is not on board with it at the beginning, but over time gets on board with it. And
Right.
so I don't think it's a clear process for many family members, and
Hmm.
I don't know that it's even a clear process for every person who has the terminal
Right.
illness. But um, but I think it's a unique process and a
Hmm.
common human experience. And so holding that it's end of life is a common human experience, and it's very unique to the person experiencing it,
Hmm.
um, is difficult to hold both at the same time,
Yeah.
and that our reaction or our end of life process might look very different than somebody else's.
Hmm.
And how can you hold both, what you would choose versus what they are choosing?
Which I think is probably the hardest thing for the family members to do, right? To allow the person who's actually going through the illness, the person who has gone through their own grief journey and has accepted that they're going to die. If you haven't caught up with them on that journey and you're still over here fighting the good fight and having so much hope for them to survive, how do you then, hold space for their opinions on their own life and their own end of life and be accepting of that? I think I've known a few people who have chosen MAID, and when they get to that point, they're very accepting of what their fate is. And as you pointed out, one of those high statistics was them feeling like they had autonomy. This is my choice. I'm not being taken by this illness. I am making a choice, to end my life, to end my suffering, which I think is an incredibly brave thing to do. But then it's the family that has been their champions the whole time. Like that's been their role, right? To just fight along with them and uplift them when they need it, to then all of a sudden have to completely flip to I'm going to accept in their minds defeat is, I think, probably a difficult thing for caregivers and supporting family members to go through. But I loved what you said, and I hadn't heard this, that we're seeing in the research that these family members are in some ways, I'm paraphrasing, thriving after, like going through their grief periods, but doing well in their grief and having more acceptance of the experience because they were able to say goodbye. I think that that's very interesting, and I hadn't heard
Most.
that yet.
Not
Yeah,
all,
right.
most.
Most,
Yes,
yes, of
some will
course.
say no, it was not. I think another common experience, though, for family members whose loved ones chose
Mhm.
MAID is the experience of needing to keep it quiet, or the
Right.
stigma around MAID and the
Yeah.
secrecy. And I think that carries a toll for caregivers or
Yes.
family members in their bereavement.
Yes.
Like they can't talk about the full, when people are grieving, it's really important that they tell their story
Hmm.
and that they talk about their loved one, and they talk about the end of life process with people that they trust. And
Hmm.
when a bereaved family member is bereaving somebody who went through
Hmm.
MAID, they might not be able to do that because of
Right.
stigma and fear of judgment around the process, and needing to keep their loved ones end of life process
Hmm.
secret for lots of reasons, to protect their own well-being or their loved ones, whatever it is. Maybe their loved
Yeah.
one requested, I don't know. And so that can create conflict for
Hmm.
the bereaved family member as well. So I don't think it's a, I don't know, I would say that they're thriving, but I
No.
would say that they have less problematic or complex grief after. And though that there are still some important supports that need to be in place for bereaved
Hmm.
family members with MAID because of the secrecy and stigma still
Right.
around MAID.
Hmm.
And um, and I would also say, uh, you there's something so powerful about people talking in grief, sharing the intimate details of the last moments of life and the
Yes.
ritual. There's a ritual with that that helps
Right.
in our mourning, in our grieving process. And so, if you have friends who have, and just to kind of, this speaks to values and how our values as individuals and also professionals or family members can influence a person's end of life process. And
Hmm.
so, like, I'm thinking about, I work with a lot of people who are at end of life, and I've worked in systems where, in states where MAID was an option and MAID was not an option.
Right.
And what I could talk with my colleagues about in one state is very different than what I can talk with my colleagues and patients about in another
Hmm.
state, and how my colleagues would or would not support that
Right.
conversation.
Right.
And
Yeah.
so there's still a lot of work to be done in our managing our own values around end of life and how people
Hmm.
choose to end their life, and can we do it peacefully and as healthy as possible without undue suffering. For
Hmm.
me with the medical aid in dying, I have to, sometimes I'll think, oh, the person has a terminal illness, but are they really suffering?
Hmm.
Are they suffering sufficiently enough
Right.
to receive MAID? And I have to challenge that automatic thought in
Hmm.
myself, like, who am I to decide
Right.
what suffering is for somebody? And
Exactly.
and I think that these conversations demand that we look at our own value
Hmm.
system and how our value system is influencing the people that we're caring for or working with if we're professionals.
Yes, no, 100%. I I really appreciate how you're able to tie in your own experiences. I think that's a really beneficial thing for people to hear, and that's something that we try to do on this channel a lot is talk about our own experiences and what we've been through so that people can see that everyone is going through something, everyone is working with an aging parent, everyone is grieving, everyone's going through that, and everyone has these snap preconceived notions in their brain that they need to work through. Like it's great that you're so open in that way as well. And I've kept you on here so much longer than I thought, but it's been such a wonderful conversation, and I really appreciate you coming on here. Honestly, I'm going to say I've been a huge fan of your podcast for a long time.
Oh, thank
And
you.
when we booked you, I had to read the email like 4 times. I did not believe
No.
it. I fangirled. I totally did. I was like
Oh my
telling everyone about
gosh.
you.
Thank
And
you.
everyone's like, okay, who is she? And I said, oh no, you don't understand. This is a really big deal.
You're one of the people who listen.
Oh my God, yes, I am. But I'm so excited that you were here
Oh,
because I just
thanks
believe
so
in what you're
much.
doing so much. And I really, really appreciate you taking the time and joining us on this cold winter day for both of us, and talking with us about these important topics. Everyone, please make sure you are following Dr. Regina Koepp and go check out her podcast, Psychology of Aging. Be number 40, 41, 42 people listening, okay? Because there's some really interesting topics on there and you're such a wonderful interviewer as well. So
Oh, thank
thank you so
you.
much for being here. It means the world to me.
Thanks so much for having me and highlighting this really important topic.
Amazing. All right, everybody, I'll see you again in a month with our next guest. Totally forgetting who it is right now, but they're going to be awesome too. So make sure you come back in a month and we will give you a heads up. Thank you so much, Dr. Koepp, and have a great day, everybody. Bye.